Good afternoon, everyone. My name is Ian Colbert. I'm the Executive Director of the Canadian Public Health Association, and it's my pleasure to welcome you to today's webinar on networking and advancing your career with mentors and advisors, which is the final of CPHA's webinar series on a career in public health shaping your future. Just be advised that today's webinar is being recorded. So the Canadian Public Health Association is the largest, oldest, and most established independent public health organization in Canada. We currently have about 1,200 members, approximately half of which are students, trainees, and young professionals. We're very pleased to present today's webinar in association with the Public Health Physicians of Canada, which is the specialty society representing public health and preventive medicine specialists in Canada. So for those of you who haven't participated in the webinar series so far, we had an extensive program from starting last September. The webinars were geared for students and early career professionals. While this is the final webinar in this year's series, we are planning to launch another 8-part series starting in September 2017. So stay tuned for additional details on that. Before we get started, I wanted to do a couple of quick polls to see who is participating in today's webinar. So first of all, let us know where you are joining the webinar from. And BC's in the lead. Oh, tied with Ontario. Oh, and Ontario's in the lead. I should have placed a bet on this. Oh, no. Okay. So not a lot from the East Coast today, unfortunately. But good attendance. So thanks very much for doing that. We have another quick poll just to help us determine what level of education you're currently at. So a few bachelors, some non-thesis masters, some masters. Excellent. Great. And then the last one today is let us know if you're a member of CPHA or PHPC or both. Oh, I see I have some work to do as far as getting people to be joining our organization. So we'll be tracking you with drones later. Great. Thanks very much, everyone, for giving us a snapshot of who's on today's webinar. So very quickly, some quick instructions about how today's webinars work. Just so you know, all participants are muted, but you can update your status throughout the webinar using the options displayed, meaning you can ask the speaker to speak louder, softer, faster, or slower. We ask that you please post your questions and comments in the chat box, and anything you type in there is visible to all participants. If we can't answer your question during the webinar today, we will follow up by email. This webinar, as I mentioned before, is being recorded, and the recording will be made available to all CPHA members and registered webinar participants shortly following today's webinar. We will make the slides and recording more broadly available 3 months after today. Then finally, at the end of today's webinar, you will be redirected to a short survey. It would be really helpful if you take a moment to complete that survey and give us your feedback. So without further ado, it's my pleasure to introduce today's moderator, Jai Hughes, sorry about that, Jai. He is a 5th-year public health and preventive medicine specialist resident at the University of Toronto. He is also one of the co-chairs of the Public Health Physicians of Canada Residents Council.
Thanks very much, Ian, and thank you everyone for spending your lunch hour with us. I'm very excited to hear from our 3 speakers. Just in terms of what's going to happen today, is each of the 3 speakers will have about a 10-minute presentation, and then there'll be just a couple minutes at the end of each of those presentations for questions. After all 3 presentations are done, we'll be able to have a longer period for some more general questions. And you can just, type your question in the chat box, which we can all see. Anyhow, if I were to get started with introductions then. So You can see on the bottom who they look like. They're all very, very handsome or pretty. We have, first of all, Andrew Gray. So Andrew Gray is a medical health officer in northern British Columbia based in Prince George. He grew up in British Columbia, but is a relative newcomer to the north, and his portfolios focus on communicable disease control and harm reduction. He is passionate about understanding and improving the social determinants of health, particularly stigma and discrimination. He attended medical school at UBC, trained in public health at McGill, and completed his residency training in the summer of 2016. Next up, we have Lorraine Telford. Lorraine is a master's prepared registered nurse who has been working in various roles to enhance public health. She has experience in all aspects of the community and public health field, including practice, administration, and education, and recently has worked to bridge the links between public health and primary care. She is currently working as a consultant in Alberta Health Services in a program to reduce health inequities. She taught community nursing and health promotion and community development and other programs and faculties at Ryerson University for many years. And after decades of direct service, she now focuses attention on advocacy to address the determinants of health that affect people unequally. She also continues to work in the consulting business Health and Family Services, founded in 1995. Last but not least, we have Paul Cseke. I hope I'm pronouncing your name correctly. Paul is an environmental health officer for Island Health, it's Vancouver Island Health Authority, working in Victoria. He is thrilled to finally be working and living in the same city as his wife. It's always very nice. The start of his career, like many, consisted of working different jobs in different locations. He loves working in public health and enjoys the diversity that being an environmental health officer brings. Prior to being an environmental health officer, Paul worked in the private food industry, both as a quality assurance technician and as a food safety auditor. When Paul is away, you'll find him playing or watching sports, and he is apparently a curler on the World Curling Tour and recently came second in the BC Men's Provincial title. So questions about public health or curling. So without further ado, I will hand it over to our first speaker, who I believe is Andrew, and the presentation is just getting loaded as we speak. So if you have any questions.
Great. Thanks so much, Ian and Joff, for the introductions. So it's my pleasure to be here speaking about my short career in public health so far. I'm speaking, as was mentioned, from Prince George, BC, which is the traditional territory of the Kootenay First Nation. And that's a picture of that area on your screen there. Okay, so we'll jump right into it. Let's see. How do I control the slides? Oh, there we go. Perfect. Okay, so this is northern British Columbia. So it's a population of about 300,000 people that live in the region that I work in. That's about 6.5% of BC's population, but 65% of BC's land mass. So it's a primarily rural and remote region. The biggest city is Prince George, which is marked by the yellow star. It's about 80,000 people that live there. But the smallest communities are as small as a couple hundred people. So quite an interesting area to work in. So what do I do? I'm a medical health officer. It's sort of the standard medical role in public health. I provide leadership and medical input on all kinds of public health matters. I work as a generalist, so I have local responsibilities. So Northern Health is divided up into 3 territories, which were colored on the previous slide. I'm in the center there, in the kind of cyan colored area, the northern interior. So for that area, I cover, on paper at least, I cover everything. So health protection in terms of air, water, food, emergency response. Public health also does facility licensing in BC in terms of, we have people who inspect various healthcare facilities that are contracted or otherwise licensed. That's a bit unique to BC. I also do anything to do with the communicable disease control, harm reduction, sexual health, more services that target individuals, and then the health promotion side, all kinds of healthy policy, healthy community work, chronic disease and injury prevention, and then of course all the services that underpin the ability to do that, so surveillance as well as supervising students and doing a little bit of training and that sort of thing. So it's a very broad portfolio. I don't actually have time to do all of that, unfortunately, at least at this stage of my career. But then I also have some specific portfolios that I work on at a regional level, more around policy and program design and planning and evaluation. And that is in co-leadership with the regional director for prevention. So mostly communicable disease control and harm reduction. So that's at least in principle what the issues I'm trying to tackle. I do that via sending lots of emails and attending lots of meetings, basically. So you have to like that kind of work. That's not all I do, of course, but that's a lot of it. And of course, it's not just me that does all that. There's a sizable team. So within Northern Health, I work with my public health colleagues who are nursing leads, environmental health officers, or public health inspectors. I've got a couple of epidemiologists, as I mentioned, the licensing services as well, various program managers, and public health within Northern Health. So the way it's structured is we're part of a health authority that oversees health services in general. And so, we're one, say, department of the health authority, and then healthcare operations and other kind of corporate services are all within the same entity. So we have a lot of partnership and collaboration with healthcare operations. Northern Health is undergoing a big integration process where we're trying to integrate public health and primary care and not have these things so siloed. So I'm often working with those folks as well as with physicians who are independent from the health authority. And then, of course, there's also collaboration with other jurisdictions, other regions of BC, the provincial level, with public health staff there, where we're coordinating on guidelines or outbreak investigations or that sort of thing. And then outside health, of course, there's all the other sectors of society that we try to work with to improve health. So municipal and indigenous governments, school boards, the police, various community organizations, the media. So it's a lot more complex than it was as a student. I must say that's one of the biggest things that I've learned so far is as a student you're kind of reporting to a supervisor, you're given tasks. You're very you're working in a very structured way. In practice, at least as a medical health officer, there's a lot of different things to do, a lot of different people to work with. It's not always quite so clear what to prioritize, who to inform, who to consult, all that sort of thing. That's the biggest skill that I think I'm picking up now that I'm in practice. So thinking about overall kind of career trajectories, I want to think a little bit about how did I get here? And any advice or experiences that I might give, whether that's useful to you or not, might depend on how much you're like me. So I want to acknowledge a few things about myself that make certain things easy for me, certain things difficult. So I'm a pragmatic idealist. It's kind of how I think about it. That means I take on really ambitious, impossible goals. Social justice for all. But then I try to work on those bit by bit in a very pragmatic way. I tend to join associations, organizations, if I can see that in principle that this seems like it might be helpful to do that, I'll join first, and I'll have to be convinced to later to not join. So that's the way I tend. I do tend to be kind of perfectionistic, which means that I work very hard, and sometimes it's not very good for my mental health. But it's probably helped get me to where I am today. I'm comfortable in formal institutions. Again, that helps. Not everyone is. You don't have to work in a formal institution necessarily in public health, though. By a few personal commitments outside work, again, that contributes to the extracurriculars I'm able to pursue. And of course, I have sort of multiple forms of privilege that mean that opportunities are open to me. I get taken more seriously in some contexts than some other folks might. So I just want to acknowledge all that before going into my kind of career path. So how did I get here in terms of the decisions that I made? I started off actually in math and computer science. I really enjoyed the sort of pattern recognition and analysis and clarity of math. So that's where I started. But then I kind of realized, that's a very intellectual pursuit. Direct service might be actually more fulfilling, so I veered into medicine. Once I got there, I realized actually the individual patient care is kind of tiring because I'm very introverted, but also not as fulfilling as bigger picture work would be. And I found public health sort of met both of those criteria in terms of having a good career. So I went into public health at McGill. While in public health, I had some particular interests that developed for me were around especially Indigenous health, resource development, discrimination, harm reduction, and I also wanted to be a generalist. I thought because I'm more interested in sort of populations than in any specific disease or risk factor. And so all of those issues are quite prominent, I would say, in northern BC, and British Columbia is also where I realized that's where I feel at home. That's where I grew up. So that's where I wanted to return. And then it just so happened that I got really lucky timing. The job that I'm currently in opened up shortly before I graduated. So here I am. So I just want to sort of highlight the general factors that I sort of thought about along as I was making my decisions. So what are my strengths? What are my values? What are my interests? What are my needs? So in terms of, for example, being back in BC where I feel at home, there's a kind of an emotional need there. And then of course, what opportunities might match well with all of those personal characteristics. So I'm quite lucky that I found something that matches all that quite well. Other things that have helped me along the way in terms of knowing about this opportunity and just learning in general to be an effective public health practitioner is joining the associations, attending the conferences. I find lots of value in doing this. So I get to exchange sort of evidence and ideas with other folks in the field. I get to meet people, mentors, role models, both positive and negative sometimes, as well as just making friends in the field. I really believe in the idea that sort of collective action that these independent organizations can do can be a lot more effective than individual action. I want to support that, and I also want to learn from it. And I also find it interesting to just observe public health, its discourse, its debates. Whose ideas have currency, kind of how the power structure works. I don't have a ton of I don't feel like I understand those things completely yet by any means, or then how to operate within them. But I find it's all useful learning that comes through attending conferences and being parts of associations. So in particular, what I've done, I volunteered on a number of committees. So I was on the CPHA Student Ad Hoc Committee for a year. When I did my master's, I joined the Student Society for a year, worked on their website. I was involved in PHPC Residence Council for 3 years. That's probably why I got invited to this webinar. Now I'm involved with my Provincial Medical Health Officers Association on their Aboriginal Health Committee. So as I mentioned before, I see value in these kinds of entities. I want them to succeed. They'll generally always accept you if you volunteer because they don't have enough people to do the work that they want to do. That's really my primary motivation. But then along the way, I've developed lots of good relationships and transferable skills, I think, through this work. And then, opportunities kind of beget opportunities. Yeah, because I was doing all that, now I'm speaking on this webinar today. So I've made a number of particular decisions about the kind of setting that I wanted to work in, but there's lots of options out there. So I'm mainly involved in practice. I'm not doing a lot of research or policy. I'm doing a tiny bit. I'm working in a government agency. There's other kinds of entities that might hire public health folks. I'm a generalist because, as I mentioned, I'm more interested in populations than in particular health issues. And I'm working at a local level, which I find more kind of more tangible in a way than working at a higher level. I find it rewarding to be kind of more directly connected with frontline practitioners and occasionally even with the public. And there's a whole bunch of different factors that lead me to make those choices. So if you're evaluating a potential career option, here are some of the factors that I found important to consider for myself in terms of the variety, how much autonomy we have, how much stability there is in the role, and then just what the day-to-day tasks are. That so I'm not seeing patients. That's okay with me. I'm at my computer a lot. That's okay. There's learning opportunities in this role, and yeah, and I came and did. I should also mention I came and did a rotation here at Northern Health while I was a resident. I like the organizational culture. I like the people. Of course, that's a big plus, and it was good to be able to evaluate that before signing up for the job. And then finally, of course, as I mentioned, BC is the location that I wanted to be in. So yeah, that's all I wanted to say. Happy to take questions now or during the Q&A later.
All right. I see that Emily is typing, but I just wanted to say thank you very much for your presentation, Andrew. That was a very systematic way of thinking about things, which is very good. So let's see if a question materializes or not. And if not, we'll move on. I guess, Andrew, you can see that question. I'll just read it for everybody. So Emily is asking that prioritizing tasks has been a challenge. How, Andrew, have you gone about doing prioritizing?
Yeah. I don't know if I have a short answer to that. I guess the shortest answer is almost by intuition. If I tried to be really systematic about it, that process itself would take up even more time. Certainly, I have my boss, the chief medical health officer, is able to direct me in terms of the general kinds of areas that she thinks are most important. Certainly, there's certain kinds of urgent issues that are either because there's an immediate health risk or sometimes because there's just a if it's a request from the media or something, you want to be very prompt with that. Yeah, I guess I think about the potential health impact on the population and sort of maintaining the good functioning of the health authority and the team, as well as sort of the expectations of the public in terms of controlling disease risks. I'd say those are kind of the factors that when it's up to me, I prioritize.
Great, thanks very much. I think we're running just a couple of minutes behind, which is good. We'll move on next to Lorraine. So loading up that presentation right now, and I'll hand it over to you.
Hi, everyone. Thank you. Just tested I could get these slides to work. Yes. Hi, I'm Lorraine, and I work in Alberta Health Services with primary care chronic disease management, but I am not speaking on behalf of Alberta Health Services today. This is not representative of their views. I'm just letting you know where I am currently employed, since this is about careers. I don't think they would disagree with what I'm going to say, but I definitely don't represent them. I am not as old as the woman in the picture up there in 1923, but I've been in public health for over 35 years. And I have done a lot of different things, and I think that I'll tell you a little bit about what I've been able to accomplish. But I wanted to say that I want to tell you a little bit about public health nursing as a discipline within nursing. I want to acknowledge that the personal is professional and political, at least it has been for me, especially when you're dealing with systemic issues. Opportunities do bang on one's door, but you sometimes have to just go for things too. And I just want to share a little bit about the work world right now and how I see it's changed a little bit. So talk about that. The first person ever hired in public health in Canada was a public health nurse, and that was in the early 1900s, related to a TB problem in the city of Toronto. This is a model that has been developed by nurses themselves. Over decades, really, there's been quite a bit of development, maybe 30 years. The community health nursing, public health nurses have worked together to define who is a community health nurse and public health nursing within that, and distinguish our unique skill set. There was a time when you had to have a degree to be a public health nurse, and now every nurse has a degree entry requirement to be a registered nurse. So the distinction between an RN and a public health nurse is one of practice standards, and some of these are listed. You can see, if you look at the green section, we have our own code of ethics. It's very different in public health. And we have a different theoretical foundation, includes epidemiology, those kinds of distinctions that you would learn in an MPH. We have different values and principles. We look at the common good and not only the Hippocratic Oath, for example. There's a different professional regulatory standards that apply to nurses in community when they work in independent situations. And we have our own competencies, like I said. This just shows you a little bit about a range of the standards that we would develop capacity in and competencies in, all the way from health promotion to access and equity and building capacity in community. It's a range, a very wide range of skill sets, and there are lots of work that can be done in communities that's quite exciting for us. So when I was a nurse in the community in the first years, I was a generalist. So I did outbreak management, communicable disease follow-up, hospital discharge follow-up, which included things like when someone had a heart attack or if someone had attempted suicide. I even followed up on a child who had rickets once and was being discharged. I did well baby and high-risk family support and home visiting, immunization, school health, seniors health, all in one job. So it was quite an experience and very broad. A lot of public health work is based on the Ottawa Charter. I just wanted to acknowledge that in this slide. You can see that it's quite reflective of the core public health promotion values. So did I know that public health and health promotion was for me? Not really. I wanted to learn more about biology, and I loved to work and travel. So in the 70s, nurses were seen as, Canadian nurses were desirable everywhere in the world. But there was also an issue in the 70s where women's work was being undervalued by everyone, even women, and people weren't even entering the profession. It was very feminized, and it still is today. It's a definite issue in our work. People think that nursing's all about caring, but my instincts at the time were right, that nursing is really about expert knowledge and efficient skills, engaging in advocacy and leadership for system change. So because the client, at the bottom of this slide, it says it's defined in community and public health nursing as an individual, family, and community. So community is client, and that I took to heart. Now, I know you probably have experienced, all of us on this webinar, difficulties in getting people to think about preventive work and primary prevention in particular. I still run into even nurses and many who think that teaching a client about their asthma is primary prevention. And I have to remind them that that's secondary prevention at the best. So we really have a lot of work to do still and to get into true primary prevention. Now, when I was at U of A doing my undergrad degree, public health school was very strong. And so then I decided to do a master's degree, and I took a long time to decide whether it would be in nursing or whatever. I ended up doing a master's in nursing, but with a minor in public health and a major in public health and family studies. So the work that I have done since then involves a lot of work with families, working with new mothers and fathers. I've been an advocate for father involvement for decades, screening for risk, providing early intensive support for families in risk conditions. And I've really worked with so many families to really understand then the real impact of the social determinants of health. And I ended up being articulate about that and asked to chair the first OPHA, Ontario Public Health Association Determinants of Health work group back in the 90s. And most people who joined the group were not there to work on addressing the social determinants of health. They had joined the group to find out what it was. So you could see how early the insight for me was on that. So I had very much a passion for prevention and a commitment to ongoing learning, tenacity for staying upstream, this allowed me to go into more of a specializing area as nursing evolved, and I started to work with early childhood health. I became even more interested in advocating for the social determinants of health, and then it was more like a household word in our field. And I worked hard to get my professional association on board for action in the social determinants of health. And again, I have the rock being pushed up the hill there because I do know that, honestly, it takes quite a bit to get that rock up that hill. The next thing I wanted to show you is just some of the volunteer opportunities that I had taken to be involved professionally in ways that perhaps it wouldn't necessarily be allowed in my work. And all of us are, when we're employed, we're an agent of that agency. You have limits. So you can create relationships with your superiors, your bosses, to participate in other programs and events. And I was always transparent about that, and I never had challenges with support for that ever in my career. So I really did have opportunities to do things as a volunteer and learning. And I did have a consulting business right from the get-go, mostly program evaluation and design and health communication. But I did continue my own learning, and I became certified as a community health nurse, and I took on leadership roles in the associations of public health and community health nursing. I contributed to the model that you saw earlier, and I always took opportunities to work on what I call pilots or projects, and you can see a couple of pictures below of a campaign we did on social determinants of health in the late 90s, and it was quite different, quite new. So those are the pieces that I'd like to share with you. And I think the thing I forgot to put on here and realized today is that I have participated a lot in personal development courses when I saw them. So sometimes they were just attitude, reflective experiences and things like that, where you just review and reflect on where you are and who you are. And those have also helped me fuel the passion and stay true to my passion. In practice, there are many opportunities as well. As you heard in the bio, I've been teaching in a few universities. I've done course writing for university programs, including early childhood programs, nursing programs. Even in the public health inspector program at Ryerson, I wrote their health promotion course. And many, many, many projects at work. And then in not nursing, I've been able to get involved through another position when I got into the primary care program. I started to look at oral health programs and chiropody and other projects that lend themselves nicely to addressing the social determinants of health in a different way, in a different field. So in every job, it's great to have somebody you can work with and for, because you can carve out opportunities in that, but it can always change in a moment. So who are you is really important, and to find your voice. I think I agree with Andrew that working with the associations and the nursing associations, CPHA, OPHA, groups like that, RNAO, has really shaped and supported me in being strong in my career, even when I'm, maybe dealing with a less supportive environment. I wanted to share with you just a little bit about what's happening in nursing, and we are having some challenges with the positions being filled, and some of them are being filled by MPH grads, which is a large number of you. And what we're finding is that the nurses are not coming necessarily with the same sort of research-based understanding, but then the MPH staff don't necessarily have the clinical experience and the direct service experience. So together, I think we can do a lot if we recognize each other's strengths. I remember the first time an MBA person came in to run a department, part of a department, and it was a really challenging environment to have them understand that we're dealing with vulnerable people, and some appointments take 45 minutes, and that's just how long they take, and not everybody's going to have a 24-minute appointment. Those kinds of conversations have always been challenging, and certainly it's been frustrating as community health nurses with a lot of experience, leadership, vision. A lot of times it does seem like the public health physicians are always the ones who lead and make the decisions in what are the priorities of public health, and there was some real shifts in public health in the late 80s in Ontario that nearly devastated the community health nursing group for a while, but of course it just made us stronger in the end. There's also a challenge in that a lot of professional groups are now moving to having a master's as a minimum entry requirement, and I think that would be that would make sense for public health nurses, but I don't know how feasible it would be. So we can do this. We can get upstream together, and whatever challenges are thrown our way, I think I would really like to be collaborative and work with all the different disciplines.
Thank you very much for that. It was really interesting hearing sort of the historical journey through a lot of things we sort of take for granted nowadays. I don't know if we actually take. Anyways, it seems you have a question. Go on.
I see Jacqueline's and Aaliyah's questions, but I just wanted to respond to that, Gia, and say that Sheila Bowser, who's a very good friend of mine and a well-known public health physician in Ontario at least, said that public health nurses were the best bargain, the best value for money in the system. And certainly if there hadn't been a huge contingent of PHNs during SARS, not that everyone's work wasn't important during that outbreak, I don't know how we would have managed, because a lot of the work was work that nurses, it was in their scope of practice to do. So that was a pretty interesting experience. So, and Aaliyah said, have you seen changes in how PHNs are being valued or undervalued in recent years? And I do think that one of the things I acknowledged was that master's level entry for occupational therapy and physiotherapy now, entry level is a master's. So I think that there is a bit of idea that there's less value when you don't have a master's degree. And I certainly, if you look at the Public Health Ontario, there's very, very few PHNs even working, in Public Health Ontario, yet half the staff in public health units are public health nurses. So I think there is an issue there. And sounds like Jacqueline had her question answered. Yeah. Yeah, and then Sheila was the medical officer of health during SARS, but then she became the chief medical officer of health for Ontario. And I think that there was one chief medical officer of health who understood and valued every single one of the public health rules and professionals, in the system, and used us, so to speak, used us well.
Yeah, I think that's something that's really important to keep in mind. We work best in teams. Okay, we're now running a few more minutes late, but that's okay. So I'm just going to hand it over to Paul, and then after Paul's presentation, we'll just have an open round of questions. Anybody or specific people? Go ahead.
Great, thanks, Ja. Great. So hey everyone, thanks for taking the time to listen to the webinar. I definitely want to thank Emma and the webinar organizing committee. It's great to be able to share experiences and listen to others in the public health world. It was really great actually listening to Andrew and Lorraine. I think it's pretty cool to hear about the experiences and routine work of a medical health officer, because sometimes in the country when we hear a medical health officer on the news, it's due to a crisis. So it's interesting to hear some of the routine work and the journey that it takes. And I definitely respect the public health journey a little more, thanks to Lorraine there. So in this presentation, I'll further introduce who I am, what an environmental health officer does, describe my career journey, and touch on some lessons along the way. So I was born in BC. I have moved around the province though. I'm now married and somewhat settled here in Victoria, BC on Vancouver Island. 28 years old. Photo on the left there is from my wedding day, and the photo on the right is me curling. I know ones listening in the prairies right now know a little bit about curling. I got a team on the World Curling Tour, and we're striving to make the Olympic trials. The Health Authority has been really good in letting me take some time off to do different events, so I really appreciate that. The sport has allowed me to see a lot of the country, unfortunately only in the winter months, so it's hard to enjoy the views in Lloydminster or in Sault Ste. Marie when it's minus 35 degrees outside. So what is an environmental health officer? When I introduce myself as an EHO to a stranger, I usually get a puzzled look. I then usually say I'm a public health inspector, because that's what they're called a lot of times throughout the country. If I still get a puzzled look, I'll usually just say I'm the person who inspects your restaurants. Yes, we do inspect restaurants and any public food service, but we also regulate many different services. This includes public and commercial pools, like hotels, drinking water systems, sewage, and personal service establishments. By that I mean like tattoo parlors or other low-risk, like hair salons on like a complaint basis. We can go in there. So the way it works in Vancouver Island is that an environmental health officer will have a geographical area. In this area, the inspector will cover all these sectors. So some other places in BC and some other spots in the country specialize their inspectors, so they'll only do like restaurants and pools. But I definitely prefer the way we have it, just because I really enjoy the variety of the work. So to become a EHO or a public health inspector, we have this national certification process done by the Canadian Institute of Public Health Inspectors, abbreviated to SciFi. So if you hear a lot of people talking about SciFi, they're either talking about movies or they're a health inspector. So the certification requires a public health degree of one of 6 schools in Canada, passing a 3-month practicum in the field, and passing a really scary 75-minute oral board exam. So a bulk of our work is done in the food industry. Each restaurant inspection frequency depends on the level of risk. So that's like, is the place have a good history in terms of infractions, or do they serve a high-risk population, like a care home? But on average, it's about twice per year. We also respond to any public health complaints. I'm very used to people describing their vomiting and diarrhea over the phone, and still Health Canada estimates that 4 million, about 1 in 8 Canadians get foodborne illness every year, so we still have quite a bit of work to do. Here's an example of our inspection reports for a restaurant. All of our inspections are shown on our website and are public knowledge. Each province have their own way of sharing this information, so you'll have to look into that on your own. But in BC, you can, on Vancouver Island, you can go to that link that's on there, or just even if you just Google like VHA inspection reports or public health inspection reports, you should find it. So you can see there's an example, one of the infractions here. Cockroaches observed around food prep areas. Cockroaches were also observed along walls and in floor/wall junctions. Additionally, mouse droppings were found throughout the facility, specifically around floor-to-wall junctions. So this obviously wasn't a very good inspection, resulting in a high hazard rating, and it may have even been a closure. That doesn't necessarily come up online. And by closure, I mean the health inspector would issue a closure order under the Public Health Act, and they have to close up until the health officer can reopen them. We also inspect pools. So you can see the bottom picture there is from the Olympics. Many of you might remember that in Rio they were having pool issues, and it was entertaining for us because we were always hearing what the news was talking about, what the problem was. So we definitely found that relatable. They do happen yearly, the inspections. We test the chemistry of the water. We look at the surrounding areas, looking for any physical hazards. We ensure facilities have proper emergency response plans, supervision, and procedures in place. So drinking water systems and drinking water system inspections take also take up a really large part of a health inspector's time. In BC, we have what's called the Drinking Water Protection Act, and we attempt to ensure all drinking water systems are in compliance. Even just on Vancouver Island, there's hundreds of drinking water systems. So let's say one house has a drinking water well and connects to another house. That would be a drinking water system, and they have to comply with the Drinking Water Protection Act. In some provinces and other health authorities, drinking water work is specialized, which means the inspector would only be doing drinking water work. But like I said earlier, I'm grateful that we have the variety here, so I can do all sorts of different work. So we also respond to sewage complaints for malfunctioning septic systems. I get quite a few of these calls because I have one of the more non-urban areas, so a lot of my area isn't fully serviced. 2 weeks ago, I had a phone call from a tenant of an apartment complex, which was on a private septic system. They said the smell was horrible and the sewage was leaking onto the road. Sure enough, I did a site inspection and confirmed it was sewage by putting environmentally friendly dye down their toilet, and then you can see the dye coming onto the road. This gives us enough evidence to issue a public health order for the owner to seize the flow of sewage and to get it professionally repaired. And then we also, I mean, if you don't know where an environmental public health complaint goes to, a lot of times it'll end up on our desk, and then I might not know about it. So there might be random air quality complaints or other public health complaints, but we do have a lot of resources, including the medical health officers, to get help with all these situations. So this slide here is just showing you that in BC we're split into 5 different health authorities. That's what I'm talking about when I say that. They're just all different employers. We all have the same laws that the province gives out, but it's just separated into this way. So I do work in the bottom left one, the Vancouver Island, the orange one. So not many people get to do this sort of career path, where you go from school to degree and then a successful career, and I'm definitely no exception to that. So over the last few years, I've had many different jobs in many different locations. It's only recently where I was successful in getting a permanent position. And I think a lot of people can relate to this model too. A lot of different generations, it wasn't exactly like this, but nowadays you have to keep on doing what you love to do, and just know that the journey will take you to where you want. So, as mentioned in the introduction, I did work as in the food industry as a quality assurance lab technician. I also went traveling, lived a year in New Zealand, which is a really cool experience. I worked in the food industry there, but that kind of gives you perspective traveling and kind of lets you know what you really want to do when you come back. So I do recommend it to anyone who's thinking about taking a year off and going traveling. And then, of course, school, and more school along the way. I have a degree from the University of British Columbia and from the BCIT, which is the technology school in Burnaby, where we get the public health degree from. I was also working as a food safety auditor, which it's kind of similar to a health inspection in restaurant in our job, which is a little more detailed. And the managers often get bonuses from your score, so it seems like they really care about food safety, but in reality sometimes there's other motives involved. So one time, even when I was working at the top of Vancouver Island, I was asked if I had a place to live before I got offered the job, and I just said yes, definitely. I didn't. I had to couch surf camp or sleep in my car for a summer, but it kind of got me to where I was now, so I don't regret it. And there's many more stories involved with that if you're curious for after. So a few lessons along the way. I just like to share that as long as you stay with your interests and passions and are grateful along the way, I think you can take and direct your career path to wherever you want. So that's all.
Great. Thank you very much. And I definitely think that what you're saying in terms of the more circuitous nature of careers is definitely a reality now for many. So we have about 7 minutes for questions. So I will just leave it to the floor. Does anybody have any questions? Just type in the box. We have a few people typing now, which is great.
Hi, this is Emma from CPHA. I can jump in with a quick question while we're waiting. I would say to some degree or another, I think all of the presenters are probably exposed to risks in their physical environment. And I just wonder how you manage that and what kind of training you receive along the way.
I can go first, Lorraine. I don't have any risks right now any more than anybody else in a cubicle in an office would have, but in the home visiting world, definitely. And I think Paul, the public health inspectors and the nurses shared some pretty interesting stories being out and about in community. Once I was chased by another vehicle for a few miles with the horn honking behind me. I've been chased out of houses when I acknowledged the family for smoking outside. Triggered something, and they chased me out of the house. The husband chased me out of the house. Definitely seen cocaine in homes, and had to deal with the ethical dilemmas around and conundrums around working through all of that, and just some of the just actual exposures to potential violence and difficult environments like that. And we did have quite a bit of training about using your instincts, and there's really good policy structures in every health department that nurses do high-risk home visiting in. We didn't ever have cell phones, which was a very interesting aspect of safety that never got fulfilled always due to budget. But there was
I can go next here. Thanks, Lorraine. Paul here. Yeah, in the health authority, we do have violence prevention training. It's not too extensive, and unfortunately, you do learn a lot of the risk management by just experiencing different situations in the field. It is kind of nerve-wracking knocking on doors because you don't really know what you're gonna get behind that door. So I have found that I like to take another inspector with me if I'm going to a unknown home. And just while I'm talking, I can just briefly answer Carly's question here. I just think that you should always get involved with your own professional organization and volunteer where you can. It's enjoyable and also helps you in your career for sure.
Yeah, I don't think I have anything, Andrew, here. I don't think I have anything to add to the risk discussion. I like Lorraine, I work in an office, and I'm not involved in a lot of day-to-day interactions with clients or out in the community. But certainly, I do work on some of the policies around workplace health and safety for our staff, and I mean, the employer should take those responsibilities quite seriously and should have policies and training and resources to ensure staff safety, whether it be from violence or infectious diseases or toxic substances or whatever the case may be.
Right, and Paul here again. I see another question from Jacqueline. And just, do you feel like EHO jobs that focus on only one topic have more opportunity to get deeper expertise in that area? Definitely. But just for me as a younger professional, I really like the diversity in work. But it's a good debate. And that's why a lot of organizations and provinces are going more towards specialized, because you can get more technical expertise if you're only in one discipline. However, the technical information, while it is kind of complex, most of our job is about communication with different people in the field. So I feel like that can transfer to many different technical areas. So I feel like the diverse work is good, but yeah, it's good debate for sure.
Just going to chime in real quickly here. I know that, Carly, you asked this question about other associations to sort of be involved with the network, and I do think that's actually quite an important part of what we do. So I'm just wondering, other than CPHA, which people are talking about, it's great, and profession associations, are there any other groups that people found particularly helpful to join in terms of early career networking? That's open to anybody.
I sometimes join the groups that are dealing with social determinants. I definitely participated in the Toronto Disaster Relief Committee, which was the housing advocacy group. They were existed for about 20 years. Participated with them at times, and so it's sort of issue-specific groups is also good. And I think that whole idea about when you're giving feedback on a document, like what's happening in Ontario right now with the Ontario Public Health Standards, sometimes you get a group of people together who meet and discuss and give feedback on a document. Like, these are really rich experiences. So like I said, pilots or projects or smaller kind of short-term issue-based activities are always worthwhile.
And in addition to the sort of broad umbrella public health organizations like CPHA, which I think CPHA and the provincial associations already provide lots of opportunity, but then there can be groups that are specific to certain professions. There's a group for public health inspectors, there's a group for public health physicians, I believe there's groups for public health nurses specifically. So I'm not as sure what there is for people with MPHs or more of an academic background, but yeah, those are areas that I've been involved in as well.
Great. Well, thank you, everyone. That was another phenomenal webinar and a great way to finish off this year's series. So thanks to Jai and all of our speakers for participating today. Just before you go, I just wanted to mention to participants that CPHA has launched a new mentorship program that's meant to foster professional development and academic opportunities among CPHA's members by connecting students and early career professionals with more established public health professionals. So the program was designed at the request of our members to help develop a supportive, engaging learning relationship that would ultimately strengthen Canada's public health system. So the deadline for applications is tomorrow. So go online and complete the application if you're interested in either being a mentor or a mentee. Also coming up in June, from the 6th to 8th in Halifax, is CPHA's annual conference, Public Health 2017. There's a ton of great events for students and early career professionals, including a reception, a breakfast session. There will be a career workshop. The John Hastings CPHA Student Award will be, there's a special session around that and lots more. So definitely check out our website for more information and details on how to register for the conference. Just want to draw to your attention some of CPHA's more recent work in policy advocacy. Obviously, we're very much following the file on legalized cannabis. We're expecting the legislation to drop sometime next week, actually. They've made a public commitment that cannabis will be legal by June 2018. I don't know exactly how they think that's going to happen, but hey, good for them. But we do have a ton of policy documents and advocacy material on our website as well. So if you have any questions or want to provide any feedback, we'll provide some email addresses for you, and you can contact us after today's webinar. So thank you all very much. Appreciate your attention and your time with us today. And as mentioned before, at the very end of the webinar, you'll be redirected to a quick survey, and we just ask that you take 2 minutes to complete that before going on with your afternoon. Thanks to our presenters, and wishing everyone a good day.